start. We are live.
Good afternoon, everyone. I welcome you all. I welcome you all to session Oncology Connect and Treatment Updates 2024. I welcome Dr. Manish Sharma, Medical Oncology Unit Head, Action Care Hospital, Delhi. Sir, please proceed.
It is not Action Care Hospital, it is Action Cancer Hospital.
Oh, sorry, sir. Action Cancer Hospital.
Thank you so much. So, good evening, everyone, and I welcome you all to this evening webinar. I thanks all of you who have joined here, my friends and colleagues. So, this is the oncological update, and specifically, we will be talking about lung cancer. As we know, it is the most common cancer and the most lethal one, and it is the cancer which is seeing the sea change in the treatment. And to decode the treatment of the EGFR mutant lung cancer, we have Dr. Pankaj. Dr. Pankaj is a senior consultant at Rajiv Gandhi Cancer Hospital, Rohini. I can see him on the screen. Sir, I welcome you to take
Thank
our
you.
first section.
Yeah, sure. I want to share my screen. Can you stop sharing the screen? Yeah. So, thanks a lot, organizers, Dr. Manish, for giving me this opportunity to discuss about EGFR mutant breast lung cancer patients. I'll just share my screen. I hope this is visible. Whether my screen is visible?
Yes, sir. Yes, it is visible.
Okay, so we'll start with the presentation decoding treatment options for EGFR mutant NSCLC patients. Since we know that major chunk of the patients when we deal with lung cancer patients, especially so in adeno CA, are ones who are having EGFR mutation positive. And in Indian context, we know that as compared to the Western world, we are having more number of patients who are EGFR mutants, and we are spoiled with choices of various agents available with us, with which we can treat these patients. And in both sexes combined, lung cancer we happens to be the second most common diagnosed cancer, 11.4% of total cases, and most common, that is 18% for the cancer deaths globally. And these are the data from the Globocon, and the parameters which determine the choice of first line treatment in advanced EGFR mutant NSCLC patients basically includes the PFS, the quality of life, overall survival. So these are the various indices on which we decide that what will be our next line of treatment. Now we had various generations of TKI, and we have data for all of them, and we can have our difference in opinion that what should be the first preferred agent to be used in these. And osimertinib provided unprecedented improvement in PFS in Flora trial that we are very well aware of. And if we talk about the PFS has been constantly increasing. First, we see that we had this Jeftinib and Erlotinib, which were the first generation TKIs. PFS was somewhere around 10 to 12 months. Then we had Afatinib, which had 11 to 13 months of PFS, depending on what type of mutation this was doing better in some specific mutations. Decometinib, ARCA trial, which did not take the brain metastasis patients, but the PFS was 14.7. But if we compare Gefitinib, which had 9.5 months of PFS, to the existing osimertinib, which is having double the PFS, 18.9 months. So this is the way forward what we have come all the way. So progression-free survival, as we have discussed, Afatinib versus Gefitinib, around 12 months. Patients, 16% of the patients did have brain metastasis. Now we had this Decometinib versus Gefitinib, the ARCER 1050 trial, which did show an improvement in the PFS to the tune of 14.7 months. But then in their whatever they had planned, the patient's protocol, they had excluded the patients with brain metastasis. But then we had this Flora trial in which osimertinib was compared to standard of choice. And we see that these two curves started separating immediately and continued to widen as the time passed by. And they had around 19% of the patients who had stable brain metastasis. So overall response rate, if we see, then overall response rate of a
Sir, you are not audible. The screen is moving, but you are not audible.
Sir, you are not audible. Devashish, can you call, sir?
Yes, ma'am.
Sure.
In a bit. Sir, Dr. Pankaj will joining in a bit.
Okay.
There is some network issue with Dr. Pankaj, I think.
Yes, sir, it seems to be.
Am I audible?
Yes,
Yes.
sir, now you are audible.
Okay, as I am not able to share the screen. Can you share the slides from your end? I'm not able to. Okay, just a minute.
Tech team, please help.
Okay, now I think you can see the screen.
Yes, yes, yes.
Okay, I'll start from where I have left. It's visible now, and I'm audible.
Yes, yes, yes.
So we were talking about the Flora trial where we had seen that there was an improvement in the overall survival with 38.6 months survival on osimertinib as compared to 31.8 months in the comparator arm. And it was a 7 months improvement in the OS, hazard ratio being 0.76. And in the other two trials, Luxlung 7 and Archer 1050, first we see that afatinib, gefitinib are more or less one above another. And in the Archer study, we see that they are crisscrossing each other in the middle. Then we had patients who were alive at 3 years, as high as 28% on osimertinib, as compared to just 9% on the comparator arm. And at 1 year and 2 year, also we see there was a huge difference. Osimertinib 70% were alive as compared to 47% in the comparator arm. So osimertinib demonstrated a superior systemic PFS benefit regardless of the disease CNS status. We see that around 18 to 20% of the patients did have stable brain metastasis. And with known or treated CNS metastasis, we see that the osimertinib showed a PFS of 15.2 months, and standard of care it was 9.6 months. Hazard ratio was 0.47. And same hazard ratio was maintained even in the patients who did not have brain metastasis. Osimertinib had a PFS of 19.1 months, while standard of care we see it was 10.9 months as was expected. So intracranial PFS, we see that osimertinib did have a very good efficacy in the intracranial metastasis as well. And as compared to standard of care, which had a 13.9 months of median CNS PFS, osimertinib, it was not reached. But here we can see with the graphs, they are wide apart, and it was statistically significant when it was compared with the comparator. So significant CNS responses, if we compare all these studies, afatinib, the median PFS was 8.2 months, and in the patients who had asymptomatic brain mets, and in another study versus gefitinib, it was 10.2 months. And decometanib, they had not taken these patients, so it was not reported. While in osimertinib, in the baseline asymptomatic CNS mets, it was 15.2 months. And patient who had uh, uh, no neurological CNS involvement alone, it was not reached, and p-value was 0.48. Safety, grade 3-4 adverse events with decometanib were reported in 63 patients in Archer 1050 trial. And while if we see with afatinib, they were 31% is lung 7 trial. So decometanib was not having a very favorable side effect profile. While osimertinib, it was just 18%. So it's a well tolerable drug as compared to the other two, namely the afatinib, gefitinib, or the decometanib. It was a better tolerable drug. And grade 3 or 4 toxicity, if we compare, then among these afatinib, decometanib, and osimertinib, afatinib is known to have a lot of diarrheas. Decometanib having skin reactions. Osimertinib, we see that these are 1 or 2% only. Dose reduction, the second generation afatinib and decometanib have been shown to frequently cause adverse event leading to decrease in the dosage. So they were more frequent in the afatinib, as we see 41%. And in Archer study, they were as high as 67%. So you can say that more than half of the patients did need a dose reduction. In Flora trial, they were as less as 4 to 5%. So hardly any patient needed a dose reduction because of the adverse event. So global quality of life was maintained in decometanib group and was significantly improved. And in Flora trial also, we see that global quality of life was improved from baseline in both osimertinib and EGFR TKI based therapy. So, if we see the sequencing, if we use suppose the older generation TKI initially, and then we go for newer generation, if they are T790 positive, we see that 7 out of 10 patients who start on EGFR TKI will not be receiving osimertinib because of the dropout rate with each cycle of therapy, and also subsequent lines we need them to have a positive T790 mutations. So doing another biopsy, having a good sample, and then having that positivity. So around 60% of the patients will be out of the osimertinib possibility getting osimertinib. So with all these drop rates, only 10 out of 3 patients will be actually able to derive the benefit of osimertinib in subsequent lines. So, and we know that approximately one third of patients will not have access to second line treatment because of various reasons, and it has been seen in various studies. Real world evidence, in Japanese study, 43% of patients acquired T790 mutation. In Taiwanese, 48%. So 50% of patients only will have this T790 mutation, and that too when they have a good pathology lab to assess that. So starting with prior generation EGFR TKI and then treating those with osimertinib, this is not optional clinical care because we are not smart enough to figure out who will be the patient who will have this mutation. And there will be one third of the patients who will be dropping, and these biopsies, tissues, and liquid biopsies not easy to handle. Then uncontrolled factors in sequencing, toxicity of drugs, occurrence of T790 mutation, sites of progression, they may have bad progressions, maybe in brain, concurrent morbidity, and patient's choice. Then this real world evidence, we see the Flower first line osimertinib trial. We had 120 patients, and they had even patients with poor performance status. And we see the time of discontinuation was better along with the PFS in the patient who was on this osimertinib. And partial responses were seen in 73% of the patient, stable disease in 23% patients. And median PFS in patient without the brain metastasis was 13.3 months, and patient without symptoms, median PFS with or without symptoms at diagnosis was 15.5 months. So diarrhea was seen more often in this, along with diarrhea, the skin rash 38%, 33%, Most common adverse event which was seen was the venous thromboembolism, which we have also seen in our patients. Then this was another study, and they had certified the patient on the basis of PDL1 status also, and disease control rate was 94.1%. And we can see that the time to failure, treatment failure was 19.5 months, and median PFS was as high as 20.5 months. So pneumonitis of all grades was higher in the FLORA trial, and most of the common cause of the drug discontinuation was disease progression, and pneumonitis was seen in around 25% of the patients, but they were more or less grade 1 or 2. Then we had this real world patients with the Mykonos study, where they had taken patients of brain metastasis also around 33%, and then these patients were assessed for their PFS on osimertinib. And again, we can see it was time to disease progression was 17.2 months. So these are the guidelines. As we can see that although there are many drugs which are category 1, but osimertinib stands tall, which is category 1 in the indications when the patients having EGFR mutations. So patients who are stage 4 who are having the sensitizing mutations, preferred therapy is osimertinib monotherapy to start with, and then we can use the other agents. So to summarize, osimertinib is the only EGFR TKI which has demonstrated a clinical and statistically significant improvement in overall survival. Flora is the first time on EGFR TK has translated PFS as well as OS, and 30% of the patients remained on this drug at the end of 3 years. And this is the only drug which can be given in patients with brain mets and T790 mutations. It is safe and least toxic among all the available options, and sequencing cannot be considered. With that, I'll conclude my talk. If there are any questions, then we can discuss that. And thanks for patient hearing.
Thank you, sir, for such an excellent talk.
Thank you.
Do you find any role of chemotherapy combination along with osimertinib as was
So we
shown
have
in
we
previous
have some
slide?
data. I think we have a data in which they have used first line chemotherapy along with osimertinib, so with some good results. So I haven't used that personally because I'm not very sure that whether that PFS one plus PFS two is equal to the total PFS of the combination. Whether sequencing or combination, what will be better, and also the tolerance also dips down. So though there's some data emerging where you can use osimertinib along with the chemo, but personally I have not used it.
Thank you so much, sir.
Thank you.
Thank you so much. So for next talk, we have Dr. Rajat. I think he has some network issue. He is not able to join. Devashish, can you please call Dr. Rajat once?
Yes, sir. Sir,
Yes, Devashish.
he has some patients to attend. So, sir, he will join shortly.
Okay, so we will wait for a few minutes.
In the meantime, Dr. Manish, are you using these PDL1 inhibitors in the first line if they are having a PDL1 positivity of 0? If yes, then what? Dr. Manish?
Yes, sir, I'm here. Can you please repeat your question?
So I was asking that if the patient is having a PDL1 negative status less than 1, are you using this combination in the front line? The
No,
PDL1 chemo?
no, sir, I don't think it helps. I don't think it helps.
Not even the ABCP?
No.
So you are basically not offering these in the front line if it is less than 1.
Chemotherapy if the PDL1 is negative. Yes, sir.
Okay.
You are using, sir.
I have offered because there was some data that you can still use them. Now, whether chemotherapy is helping or it's just the immunotherapy, I don't know. So,
But
2-3
practically, I think, yes, Dr. Abhishek is here. I think we can start with Dr. Abhishek. Dr. Abhishek,
will not be knowing.
no, he has joined, sir. We'll call Dr. Abhishek. Devashish, can you call Dr. Abhishek once?
Yes, sir.
And are you doing NGS on every progression in the patients of metastatic CA lung? Adeno.
No, sir, not on every progression, but at least once the patient is on osimertinib and then he is progressing, at least for once I am doing. For every progression, I think it is very difficult to do.
No, but I think there is some recent data that is preferable that you do this NGS on every progression because many of these patients will have some new targetable mutations. Not
So,
very common, but if patient can afford, then yes.
so you are doing all the comprehensive gene panel, all the 500 genes, or just some
No,
of the
no, no.
target mutation?
Usually, depending upon the affordability, you usually go for that 20 gene panel, which including the common is one for which drugs are available.
One for which drugs are available, right?
Yeah, so we do that.
So for every time you do a fresh biopsy, sir?
We ask the patient if the patient, we give an option.
Or
If the
you do a
patient
liquid biopsy?
yeah, then we go for a liquid biopsy.
Okay. I think that is the right strategy, sir.
Yeah.
So we have many panel patients, and all the panel patients, they don't get permission so easily for
Okay.
NGS testing. So अगर एक दो बार भी करवा लेते हैं, so that is more than sufficient for them.
नहीं वो तो ठीक है. I thought panel patients you have freedom to do anything.
No, so for special testing, they have to get a special permission.
Okay.
So any test which is beyond some 50,000 rupees, you have to get permission for every time, and it will take at least 15-20 days for all the
If you
permissions.
talk to your management, they will do this test in 49,500 rupees. Yeah. So has next speaker joined? Maybe you can start.
Devashi is connecting. Try to connect with Dr. Abhishek and Dr.
So I think, yes, I can start my talk.
Yeah, that will be good.
So I will be speaking on the real world evidence for osimertinib. What real world data is there, and you can see my screen.
Yes, sir.
So few of these studies, Dr. Pankaj has already mentioned about the Mykonos study and the Flower study. So I will be taking these studies in detail. And so this is a real world evidence, the osimertinib as a first line treatment in the EGFR mutant NSCLC as a standard of care, and what are the real world evidences. So in the patient with EGFR mutations, PFS improves after treatment with EGFR TKI compared with the cytotoxic chemotherapy. And the osimertinib is an irreversible third generation EGFR TKI that demonstrated a clinically meaningful improvement in the median progression-free survival, as Dr. Pankaj already alluded to, with a phase 3 randomized FLORA trial. So we have the evidence in the form of phase 3 FLORA trial. And the overall survival is the median. Overall survival is 38.6 months, which is not seen with any other oral TKI, versus 31.8 months for the standard of care oral TKI. So this is FLORA trial. I will not go into detail. Dr. Pankaj have already detailed this FLORA trial. A brief about it: the patients who were exon 19 deletion or L858R mutated patients, they were not previously exposed to any systemic chemotherapy or systemic EGFR TKI treatment. They were randomized into osimertinib versus gefitinib or erlotinib. And the RECIST 1.1 assessment criteria was used. It was every 6 weeks until the objective progressive disease was demonstrated. And the OS was key standard endpoint, secondary endpoint of this FLORA trial. And this is the baseline clinical characteristics. Most of the more patients, they were female. Median age was 64 years, and more patients were Asian as compared to non-Asian, non-smokers, because most of the patients, they have non-smoking status who have adenocarcinoma. And please see that there were 19 patients in the osimertinib arm who had CNS metastasis at entry, while 23 patients had metastasis and CNS for comparator EGFR TKI. And the overall disease classification, metastasis 95% versus 5% advanced, and all the patients, they were adenocarcinoma except 1 or 2 patients. And the EGFR exon 19 deletion and L858R mutation were present in 63 versus 37% patients respectively. And you can see that there is a wide separation of curve starting from the beginning. It has started to separate, and you can see that progression-free survival for osimertinib is 18.9 months versus 10.2 for gefitinib or erlotinib, and the hazard ratios were statistically significant, and they were 0.46. And on the right-hand side, you can see the subgroup analysis, and none of the subgroup favored the gefitinib or erlotinib arm. All of them, they favored the osimertinib arm, irrespective of CNS metastasis or smoking history, race, age, or type of mutations. And this is the median overall survival for the FLORA trial. It is 38.6 months versus comparator EGFR TKI, which is 31.8 months, and hazard ratio was 0.799. So in conclusion, the FLORA showed statistically significant and clinically meaningful overall survival benefit. Median OS for patients with osimertinib arm was extended by 6.8 months. And this is the monotherapy that is significantly shown to have CNS penetration as well, and favorable and consistent toxicity profile despite the prolonged exposure in the osimertinib arm. So the final OS analysis of the FLORA reinforces the osimertinib as a standard of care for first-line treatment for patients with EGFR mutant advanced NSCLC. And this is the slide which Dr. Pankaj also showed. The osimertinib is the preferred treatment. It is category 1, although other category 1 recommendations are erlotinib, afatinib, gefitinib, but dacomitinib. But still, the preferred treatment is the osimertinib for EGFR mutant NSCLC. And nowadays, we have the option of adding chemotherapy to the osimertinib in the form of pembrolizumab plus carboplatin. So coming on to the real world evidence of osimertinib, these are the studies: FLOWER studies, OSIFECT study, and MYCORNOS study. So coming on to the first study, that is the FLOWER study. So osimertinib, this is just a brief introduction. We have already seen these in the previous slide. Osimertinib is an irreversible third generation EGFR TKI that has demonstrated clinically meaningful improvement in median progression-free survival. Overall survival is 38.6 months, and the hazard ratio is 0.80. and it has been estimated that only 2 to 4% patient with the cancer receive treatment within RCT, and thus raising the issue of representativeness. We all know that the conditions in which the clinical trials are done, they are very strict, and the inclusion and exclusion criteria, they are very, very strict. And only 2 to 4% of the patient can receive the cancer treatment within the RCT. Rest of all, they receive it in the real world. So real world data has hence become a useful tool to assess the unique insight in the routine oncology practice in the post-marketing setting. So these are the key clinical features. Median age was 68 months. Then you see brain metastasis. Brain metastasis was present in the significant number of patients. That is 30% patient had brain metastasis in this. 120 patients, they were adenocarcinoma, and similar to the FLORA trial, the never smoker were 54% versus 34% in the former smoker. And more patients, they were stage 4B, that is 71%, and stage 4A were 23.8% patient. Bone metastasis diagnosis was present in 46% patient and absent in 53.2% patient. And the best response to osimertinib, you can see the CR was not achieved by any patient, but 73% patient, they achieved partial response, while 23% patient, they achieved stable disease. And hence close to 96% patient had overall response rates. So these were the inclusion and exclusion criteria for this study. More than 18 years of age, histologically or cytologically confirmed NSCLC, in the presence of one or more epidermal growth factor receptor mutation in exon 18 to 21, locally advanced, recurrent, or metastatic, as done by 8th edition of TMB classification of the malignant tumors, and the eligible to receive first-line osimertinib with third-generation EGFR TKI, that is osimertinib, and those patients who received study drug in clinical trial, they were excluded from the study. The study endpoint were median time to treatment discontinuation, which was the primary endpoint, and it is under exploration as a pragmatic real-world endpoint to assess the efficacy of the anti-cancer therapy in NSCLC, and it reflects the common practice to continue the treatment beyond RECIST progression. Second is rate of treatment-related adverse event. Third was the rate of dose reduction, temporary or definite treatment interruption due to adverse events. And the secondary endpoint were median overall survival, median PFS, overall response rates, and disease control rate, and the diagnostic therapeutic pathway, the time frame between the diagnostic biopsy, histological report, the proportion of the patient underwent loco-regional treatment, and the type and frequency of the rebiopsy performed at the progression. So you can see the primary effective assessment, that is efficacy, effectiveness. The patients with the poor performance status, comorbidities, and rare EGFR mutation and active brain metastasis, they were included, which were not included in the FLORA trial. In FLORA trial, we had patients who had performance status of 0 to 1 with no comorbidities, and the rare EGFR mutations, they were excluded, and only the stable brain metastasis were included. The outcome were similar to the published data, thus adding the consistency to the osimertinib efficacy. No difference in PFS, time to treatment discontinuation, overall survival were noted in the elderly patients, patient with comorbidity, and less common EGFR mutation. And you can see the median time to treatment discontinuation on the left-hand side was 25.3 months. And the median time to treatment discontinuation with no symptoms versus those patients who had symptoms at diagnosis. So those patients who had symptoms at diagnosis, they did not do as good as those patients who had symptoms at diagnosis, who had no symptoms at diagnosis. Similarly, median time to treatment discontinuation with less than 3 metastases or more than 3 metastasis site, they differed. And those patients who had less than 3 metastatic site, they fared better as compared to those patients who had less than 3 metastatic site. So time to treatment discontinuation appear to be more suitable endpoint to evaluate the treatment outcome in the pragmatic real world trial. Time to treatment discontinuation was longer, 25.3 months, than the post progression outcome analysis of the FLORA trial, that is 20.8 months, probably due to the study population unfit for further therapy and the different therapy for oligoprogressive disease. And the better time to treatment discontinuation was associated with fewer than 3 progressive site isolated progression compared with the oligo or systemic progression. So these are the overall survival univariate analysis. And as I have already mentioned, those patients who had symptoms or who had 3 metastatic site at diagnosis or who had presence of symptoms, they were the negative prognostic factor. So it indicates that the disease load is a negative prognostic factor in this study. And these are the various p-values and the hazard ratios for those patients who had number of metastatic sites less than 3 or more than 3 brain metastasis at present at the treatment start of the treatment, liver metastasis, bone metastasis, and the best treatment response. So these are various PFS univariate analysis of the OS and PFS. Coming on to the complete responses, there were none. Patient did not respond completely to the treatment. Partial responses were present in 73% patient, and the stable disease was present in 23% patient. The progressive disease was present in 4% patient. And you can see that as we had discussed, the median PFS was better in those patients who had brain metastasis, who did not have brain metastasis versus brain metastasis. And the median PFS was better in those patients who had who did not have symptoms as compared to those who had symptoms. So the longer PFS was noticed in the absence of brain metastasis, median PFS not reached versus 13.3 months. Prolonged PFS and longer OS also noticed in the patient without symptoms at diagnosis, and time to treatment discontinuation of 9 months or higher was significantly associated with better PFS, better OS. So those patients who had time to treatment discontinuation of more than 9 months, they had better overall survival. So among the patient experiencing progressive disease, 47.7% patient underwent rebiopsy at the progression, tissue rebiopsy 66.7%, and liquid biopsy 28.6% patient. Molecular analysis was performed in 61.9% patient, in which the MET amplification was seen in 4, MET and EGFR amplification was seen in 1, and EGFR amplification seen in 1, and HER2 new amplification was seen in 1 patient. Safety, coming on to the safety analysis of the osimertinib in this real world study, and you can see that the safety analysis was almost similar, except for a few things which were not very much highlighted in the FLORA trial. And although we don't see that many adverse events with the osimertinib in the real world setting, but here we found that the venous thromboembolism was present in 9.5% patients. Grade 3 or 4 the venous thromboembolism was 7.9% patient, and the dry skin, paronychia, ILD, pneumonitis, diarrhea, and stomatitis, they were also present. So 87% patient experienced the adverse events, 42 of grade 3 or 4. Venous thromboembolism was most common. In the real world asterisk study, grade 3 pulmonary embolism accounted for 2% of the pre-treated patient receiving osimertinib. and no differences in the VTE was reported according to the age, PS, comorbidity, and tumor load. No difference in the survival outcome was observed according to the age, comorbidity, and type of EGFR mutation. And osimertinib confirmed effectiveness and safety in the real world scenario. This is the second study, that is OCFACT study, osimertinib as a first-line treatment for advanced epidermal growth factor receptor mutation positive non-small cell cancer in the real-world setting, that is OCFACT study. And in the patient with EGFR mutation, PFS improves with EGFR TKI osimertinib as compared to the toxic therapy. We know that, and osimertinib has shown to be superior in the first generation EGFR TKI in terms of overall survival. And the current study investigated the difference of the efficacy with the patient background and the safety of the first-line osimertinib treatment in the real-world scenario. So these were the inclusion criteria: advanced EGFR mutant and SCLC with osimertinib as an initial treatment. Patient concurrently using other anti-cancer therapy or undergoing thoracic radiotherapy, they were excluded. Undergoing post-operative adjuvant chemotherapy, they were excluded. And those receiving osimertinib as a second-line treatment, they were also excluded from the study. And these were the baseline clinical characteristics. Significant number of the patient here had asymptomatic or symptomatic leptomeningeal enhancement. So this is also one group which was not studied in the FLORA trial. Then patient had pleural effusion, pericardial effusion. They were symptomatic or asymptomatic in 16% patient, and the liver metastasis was also present in 7.4% patients. So primary endpoint was progression-free survival, and the secondary endpoint was overall survival, time to treatment failure, response rate, safety, and post-treatment, complete response, partial response, or stable disease or progressive disease, objective response rate, CR plus PR, and the disease control rate, that is CR, PR, and stable disease. So PFS event occurred in 182 patients out of 538, and there were other parameters that were significantly associated with PFS, that is male gender, malignant effusions, liver metastasis, and advanced unresectable disease. So you can see that here the hazard ratios were more than 1, and these were the adverse factors that were associated with PFS. And with respect to PDL1, the median PFS was not recordable in patients with TPS of less than 1%, 14.7 months with TPS of less than 49%, 11.1 months for those with TPS 50%, and not recordable in the patient with the TPS unknown. So this I have already discussed. The primary endpoint, PFS, the male gender, it was, the hazard ratio was 1.99. Malignant effusion, the hazard ratios were 1.51. And those who had liver metastasis, the hazard ratio was 1.55. So these were adverse factors that were associated with the progression-free survival. Treatment discontinuation profile. So 44% patient, they discontinued treatment due to the disease progression. 25.6% patient, they discontinued treatment because of the pneumonitis. So this is one of the important adverse event which we should be keeping in our mind, because the original study of the FLORA did not show such a huge pneumonitis in the FLORA trial. And the 16% patient, they had some other adverse events, like which have been listed here as anorexia, skin disorder, cardiac failure, or QT prolongation, thrombocytopenia, etc. And the 14.2% patient, they either did not come for follow-up, or because of the patient request, they were taken out. So it is this pie chart importantly tells us that the disease progression, pneumonitis, is very, very important side effect which has to be seen in all the patients. And the median duration of the onset of pneumonitis is 56 days. Grade 3 toxicity, non-hematological toxicity, 53 days. And this was the conclusion of the OCFECT study. The overall response rate was 76.2%. Disease control rate was 94.1%. PFS is better with osimertinib than with conventional EGFR TKI. Median time to treatment failure was 19.1 month. Median time from start of treatment to the onset of adverse event was 56 days. Pneumonitis of all grade occurred in 69 patients, or that is 12.8% patients, and grade 3 or higher in 4.5%, and fatal pneumonitis in 0.7% patient. The PFS was first-line treatment, first-line osimertinib treatment in the real-world practice was favorable, and the discontinuation rate to adverse events was 18.8%. Especially pneumonitis needs the further investigation, as I mentioned in the previous slide also. This is another study, real-world study of the patient with EGFR mutant locally advanced metastatic NSCLC treated with the first-line osimertinib. And the background we have already discussed in the previous studies also. We have discussed about the FLORA trial. But this study reports the demographic and clinical characteristics, real-world time to new treatment or death, and real-world time to treatment discontinuation of the patient with advanced EGFR mutant NSCLC who received first-line osimertinib in the United States. And this was a global observational prospective cohort study which is ongoing in US, Europe, and Asia, and it involves the analysis of the registry and the electronic health record data from the country-specific data sources in the participating countries. And for this, during the study period, the de-identification of the data was done from the 280 US cancer clinic on the 800 sites of the care. And for this interim and subgroup analysis, data analysis was collected through June 30, 2020, and the study is ongoing. The follow-up period is planned until June 2023. And the patient inclusion criteria were more than 18 years of age, advanced NSCLC, EGFR mutant, documented prior to the initiation of first-line osimertinib, and the initiation of the first-line osimertinib from April 1, 2018 to March 31, 2020. So this is the study design. January 1, 2021, an advanced NSCLC diagnosis at the diagnosis start date. And the first patient identification date was April 1, 2018. And the March 31, 2020 was the patient identification end date. And the study is still running, still continuing. And these were the statistical analysis which were done. Kaplan-Meier curves they were used to generate and the estimates for time to new treatment or death and the time to treatment discontinuation, and adjusted and unadjusted Cox proportional hazard model. They were used to assess the association between the baseline covariates and the clinical outcomes. And these were the socio-economic and socio-demographic characteristics. The median age was 70 years. More than 75 years of the age was 35.2% patient, which were not included in the FLORA trial initially. Then most of them were females. And here the whites and the Asian, they were around, whites were 53%, Asian were 13%, and Black or African American were 7.3% patient. EGFR mutation positive, 100% patient, and the common mutation only, that is EGFR exon 19 deletion or L858R mutation, 51.1% patient and 33.7% patient. Both common and uncommon mutation 4%, uncommon mutation only 9.5%, and unknown mutation 0.9%. And these were the treatment sequencing. 318%, that is 58% patient remain on first-line osimertinib therapy or they were lost to follow-up. 18.8% patient received second-line treatment, which included PD-L1 monotherapy or the combination, monotherapy or the combination, and 18.4% patient died while on first-line treatment, and 4.7% discontinued treatment on the first-line treatment. And this was a real world time to next treatment or death. It was 17.9 9 months. Median follow-up time was 9.6 months. There were 204 events, 18.4% patient died, and 18.8% patients switched to second-line treatment. So, in the multivariate analysis, following variable were significantly associated with real-world time to new treatment or death, and they were staged at initial diagnosis, smoking status, Charlson comorbidity index of more than equal to 3, EGFR mutant type, and number of metastatic site more than 4. So these were inversely related to the median real-world time to treat new treatment or death. And this is the real world time to treatment discontinuation. It was 17.2 months. And similarly, it was inversely associated with Charlson comorbidity index of more than equal to 3, ECOG performance status of more than equal to 2, EGFR mutation type, the number of metastatic site more than 4, and evidence of liver metastasis. So the study provides a real-world insight into the use of first-line osimertinib in the patient with the advanced EGFR mutant NSCLC based on the first data cutoff analysis of the US subpopulation, and the interim real-world time to new treatment or death and real-world time to treatment discontinuation results support the effectiveness of osimertinib in this real-world population, and longer-term outcome will be evaluated in the final analysis. Thank you so much for your patient listening. If there are any questions, we can take a few questions. Dr. Abhishek?
Yes, Dr. Manish.
So,
Good evening.
good evening. Can we take your next session?
Yeah, absolutely.
So, Dr. Abhishek is a senior consultant at Yashoda Hospital, and he will be taking us through the molecular markers in the lung cancer. Over to you, Dr. Abhishek.
Very good evening to you all. Thank you, Dr. Manish and the organizers for having me here. So the topic for discussion today is the molecular biomarkers in NSCLC. I'm sharing my screen. Is it visible?
Yes, yes.
Okay. So we will be discussing the things under four headings: the lung cancer scenario in India, the biomarker testing in non-small cell lung cancer, and evolution of biomarker tests in NSCLC, how the evolution took place as our understanding got better with the trials and with the experiences from past to the current scenario, and the key takeaway messages. So the burden of lung cancer according to Globocon 2020. So we can see that the number of new cases in 2020, both sexes, all ages, the lung cancer shared to be the fourth most common, which is a 5.5% in terms of the new cases. And in males, it was second. So the bird, again, going ahead, we can see that as many as 72,000 patients, new cases come up every year. And the number of deaths also, the lung cancer ranks fourth. So 50% patients with advanced NSCLC have a driver mutation which is targetable with an approved FDA approved agent or a clinical trial. So we can see that the most common oncogenic driver mutation is the EGFR sensitizing mutations, that is 17%, which is actionable. Earlier it used to be the most common, now it is the KRAS, which is 25%. And amongst KRAS, it is the KRAS G1C. And second most common is EGFR. Third most common is ALK. And there are small percentages of MET HER2, ROS, BRAF, RET, NTRK1, PIK3CA, and MEK1. So these are the various targetable agents. We all know that against all these mutations, there are some kind of tyrosine kinase inhibitors or monoclonal antibodies that are available. So for ALK, we have crizotinib, from crizotinib to brigatinib, lorlatinib. For EGFR, we started from gefitinib to osimertinib. For KRAF, it is sotorasib and adagrasib. For EGFR exon 20 insertion mutations, amivantamab and mobocertinib. And for HER2 new, it is trastuzumab deruxtecan. For ROS1, crizotinib and entrectinib. For BRAF, it is dabrafenib. For RET fusion, it is selpercatinib, traseltinib, and NTRK fusion, entrectinib, and larotrectinib. Just a second. So the importance of biomarker testing in NSCLC. Studies have shown that patients with identified actionable mutations who receive appropriate targeted therapy have improved outcomes. So these are the survival curves plotted against time, and we can see that the blue curve is showing the patients who receive targeted therapy, and the red curve shows patients who didn't receive a targeted therapy. So the median EOS in the patients who received a targeted therapy was 18.6 months, and the median OS in patients who didn't receive any targeted therapy was 11 months. So 7 months almost there was a difference, and this difference persisted over the time. The survival advantage of the targeted therapy. So guidelines, there are various guidelines, treatment guidelines, which recommend routine biomarker testing to guide treatment decisions in advanced NSCLC. And we can see that the most common guidelines are ESCO, NCCN, ESMO, and ISCLC. NCCN and ESCO almost recommend the testing of all these biomarkers, including the PDL1 expression. ESMO and ISCLC skip few, like the rare ones like BRAF, MET exon, 14 skipping mutations, RET gene fusions, and KRAS mutations. So method of tissue testing in SCLC. Now this is again a very confusing and a very challenging topic to understand. So the tissue testing method can be a DNA sequencing by either NGS or PCR, which can detect insertions, point mutations, deletions, can detect aberrations in EGFR, KRAS, BRAF, HER2, MET, and there are single gene or full genome next generation sequencing panels. Then there are RNA sequencing panels which detect fusion abnormalities and are more sensitive for ALK, ROS, RET, and NTRK. So for most of them, I think DNA sequencing is good enough, but for few genes, as we have seen, RNA sequencing panel is a bit better. Then there is IHC and fluorescent in situ hybridization. FISH detects ALK and ROS uh, very nicely, and they are FDA approved tests for detecting these two alterations. IHC also detects ALK and ROS1, and it is a cheap and easy test, very fast, though not reliable and sensitive enough to guide the treatment. IHC detects the PDL1 testing, which is again the method of choice for detecting PDL1. So evolution of biomarker testing in SCLC, past and current. So we can see that tissues can be from resections, that is, or excision biopsies, or the large specimens or the resections of the surgery. And then there can be small tissue biopsies like core biopsies, which can be formalin fixed paraffin blocks, fine needle aspiration, or exfoliative cytology, that is the cells shed from body surfaces, and it can be in the form of a slide block. Then can be liquid biopsies, like there is any tissue fluid coming out or the blood. So there are various key personnel involved in the handling and obtaining of these tissues, like surgeons, pathologists, interventional radiologists, mostly in our country. So we can perform a histology, cytology, and then we can put a parallel diagnostics like IHC, ISH, or FISH. So DNA can be assessed by PCR, cancer gene panels, MSI, WES, WGS, targeted mutations, RNA, by RT-qPCR, gene expression panels, RNA sequencing. So proteins can be studied with proteomics. So biopsy establishes diagnosis, determines histological subtype, and forms the basis of a biomarker testing. So histological subtype is first of all established whether it's a squamous or non-squamous. For biomarker testing, we can choose the primary tumors and the metastatic lesions. Bone biopsy can be suboptimal because while undergoing decalcification, there can be a significant degradation in the DNA yield, and liquid biopsies are another option. Tests for EGFR cross, BRAF, and TRK-RAT met exons 14 in all non-squamous cell carcinomas, non-small cell carcinomas. Use broad NGS testing to detect most mutations using least amount of tissue. So this is the benefit of an NGS panel, that with a very less amount of tissue in one go, we can test all these mutations which are targetable. For squamous NSCLC, consider testing in young, never light smokers, or if biopsy specimen is out of mixed histology. So we also know that there are small biopsies can be a bit tricky, and there are patterns of differentiation in a tumor. At one place it can be squamous, or it can be at one place it can be some mixed type, or in some place it can be adeno. So if the patient is young, never light smoker, or a female, then all these biomarkers should be invariably tested in case of a small biopsy specimen. And tests for PD-L1 expression should be done in all NSCLC patients. Completion of testing within 10 to 14 days of biopsy is recommended. So circulating tumor DNA testing has the potential to be applied across all the stages of NSCLC and throughout the treatment pathway. Uh, Diagnosis and treatment selections, ctDNA genotyping is recommended for clinical use in advanced NSCLC to guide treatment selection under specific circumstances, like in resectable NSCLC. ctDNA testing is not a part of current clinical recommendations, but may be applied in the setting in the future as a biomarker. So monitoring prognosis, response to treatment, and progression or relapse disease. So ctDNA has several potential applications to predict or monitor clinical progression or recurrence in both early stage and advanced NSCLC. This we'll see later in detail. And ctDNA testing over the tissue challenges associated with tissue testing, minimally invasive for patients, allowing for serial biopsies if needed. We know that as the time goes by, the tumor keeps on gathering new mutations for developing resistance or otherwise also. So if we need an NGS again, it is very difficult for us to convince the patient to undergo a biopsy. And sometimes the tumor is at such a place that doing a biopsy can be really tricky or risky. So the ctDNA proves to be very helpful in following up such patients. ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with NSCLC. ctDNA may be used to detect minimal residual disease after surgery in resectable NSCLC. So this was an very interesting study, which is the TracerX study. So 24 early stage NSCLC patients were followed longitudinally after resection. And and phylogenetic ctDNA profiling was done. So almost 90%, that is 9 out of 10 patients with recurrence, without recurrence for MRD negative. So this is a very interesting thing that ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by any. This can come out in future in a great way, and this can very well help us in guiding the adjuvant treatment or the patients who need to be kept under very strict follow-up. So comparison of tissue versus liquid biopsy testing, there are similarities and differences between tissue tumor and the liquid biopsy testing for molecular alterations. So obtaining a tumor tissue is invasive. Liquid biopsy is very simple to draw. Generally 10 ml of whole blood is required. So repeat sampling, serial testing challenging with variable biopsy and patient risk. It is again a risk-free procedure. Liquid biopsy is again a risk-free procedure. And you know, the lower tumor content acceptable with sensitive techniques, sensitivity of the and very sensitive methods required, as ctDNA may comprise less than 1% of the total DNA that has been extracted. So we need very sensitive assays for liquid biopsies in comparison to the assays that are done on the tumor tissue. So as far as analytical standardization is concerned, the tumor tissue uses existing validated tissue processing and handling procedures. Standards for analytical performance characteristics of ctDNA or cfDNA have not been established. So no guideline exists regarding the recommended performance characteristics of the liquid biopsies. And as far as the evidence of clinical utility is concerned, substantial evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure and advanced NSCLC. We have a very substantial evidence in terms of tumor tissue. In terms of liquid biopsy, this is a younger technique, though there is less but increasing evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure and advanced NSCLC. Because as you know, we have already discussed that the tumor mutations evolve with time, and it is not possible practically to do the biopsies again and again. So multiple genes involved in NSCLC, we have seen that there are almost 8 to 10 genes that can lead to the development of NSCLC, and single gene reflex testing or multiple gene testing required by NGS. So this is a decision which used to confuse us till some time ago. Then I think depending upon the institution we are practicing in, and depending upon the finances of the patient, and depending upon how rapidly we want to start the treatment, I think each one of us as a medical oncologist has followed their own path. Nothing, nobody is wrong, but then we all have started using these single gene testings or the NGS as per their and the patient's comfort and for the benefit. So what are the advantages of NGS? So NGS has a number of advantages over single gene tests. So as the number of clinically actionable biomarkers has increased, the ability to evaluate all known molecular alterations in a single test gives NGS a major advantage. So if one or few molecular markers are needed, then it becomes a costly procedure. If many molecular biomarkers are needed, then it reduces the cost, shorter turnaround time, and lower tissue requirement versus the single gene testings. So if you see the cost, uh, this single gene testing weighs over NGS. And if molecular markers are needed, then the balance tilts in the favor of NGS. And in the turnaround time, if you see the single gene, if few biomarkers are needed, the balance tilts in the favor of single gene testing. But again, if multiple biomarkers are needed, then the balance tilts towards the next generation sequencing. So pros of using NGS versus single gene test detects a broad range of molecular alterations in a single sample, may identify new biomarkers that could offer additional treatment options for a patient and provide information to help with development of new and more effective treatments. Cons of using NGS: high complexity of workflow that requires experienced personnel interpret rapidly, and patients and the clinical community must receive sufficient education in this area. So this is a relatively newer technique which needs very good experience and the software and data analyze techniques and molecular landscape in SCLC. So we can see that SNVs and CNVs variant types. So single gene assays, Sanger sequencing, pyro sequencing, allele specific PCR, single base extension, multiplex ligation dependent probe amplification, mass spectrometry, gene panel assays like amplicon based panels, hybrid capture test sequencing, next generation sequencing, and fluorescence based methods like fluorescent in situ hybridization and microarray based. So this slide shows the various techniques that are used for mutation detection. So we can see that EGFR is present in 30 to 40% patients, KRAS in 20 to 30% patients, the frequency MET in around 2 to 5, ALK in 3 to 7%, BRAF in 0.5 to 5%, ROS1 2 to 3%, RET 1 to 2%, NTRK 1 to 2%, HER2 1 to 5 percent, and there are rare mutations like PTF, P10, PDGFRA, PIK3CA, TP53, RB2, TERT, and CDK and 2A. So EGFR mutation in lung adenocarcinoma. Sample types used for EGFR mutation testing are FFPE sections, fresh frozen or alcohol fixed specimens can also be used for PCR-based assays. So, but the most common ones that we use are the FFPE sections. Cytology samples can also be used. Cell blocks are preferred over smears. And we can see that there is a very good concordance in the EGFR mutation status in primary tumors and the corresponding metastatic sites. So discordances are rare. So EGFR mutation testing in early lung cancer. So it is recommended that from stage 1B to stage 3 NSCLC, the EGFR mutation testing should be done for adjuvant decisions. What are the advantages of NGS over PCR? Study showed that 48.6% of EGFR exon 20 insertion mutations identified via NGS are missed by PCR. Out of 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified with PCR. So I feel that especially with the newer drugs coming up for EGFR exon 20 insertion mutations, like amivantamab, I think this is one mutation where NGS definitely scores over the traditional PCR. Now, ALK rearrangements in NSCLC, we know that earlier we used to do IHC and ALK. They are still the standard test that we do. IHC is quite cheap. The most common antibody that we use is D5F3, and it has a very, very good correlation with the fish uh, testing as well. So false positivity rate of 0.1% with fish. So this is one thing which doesn't happen with NGS. So IHC is less expensive and hence more commonly adopted. ROS1 rearrangement in NSCLC, we can see that it can be performed with IHC and the break apart fish both. So detection of elevated ROS1 protein levels by immunohistochemistry may provide cost-effective screening prior to a confirmatory fish testing. So if it is positive IHC, it has to be reconfirmed by a fish. So now the KRAS mutations. So we know that the RAS-RAF pathway is a very, very important pathway in oncogenesis. And RAS sends activating signals to a number of cellular pathways that are involved in cellular proliferation and survival. So we already saw that KRAS mutations are mutually exclusive with EGFR and ALK mutations. So if there is a KRAS mutation, we can practically we can practically think that there will be no EGFR and ALK mutations in the same patient. And they account for 30% of lung adenocarcinomas. The most common of these arise in codons 20 and 13, with the G12C variant found in 13% of patients with lung adenocarcinoma, predicting poor prognosis versus wild type KRAS. So the method of detection is a multi-gene NGS panel. Sotorasib is currently approved for patients with NSCLC, and trials with adagrasib have showed potential in early phase 2 and 3 trials. BRAF testing in NSCLC, the BRAF V600E mutation is the most common BRAF mutation seen in patients with NSCLC and is more prevalent in smokers. Other non-V600E mutations such as V600K, G466V, and G469A are less prevalent and occur in 17% of patients with a BRAF mutation. Overall, BRAF mutations occur in 1 to 5% patients with NSCLC, most commonly adenocarcinoma. So method of detection, again, NGS is generally used for the multi-gene test panel. The targeted therapy, the currently approved therapies for BRAF V600E mutation is dabrafenib plus tremetanib. Impact of other BRAF mutations on therapy selection is not well understood till now. Resistance generally develops via a pathway that bypasses RAF, such as redirection of cell signaling via the downstream MAC1 or 2 kinases. Now, the c-MET receptor tyrosine kinase and the exon 14 skipping mutations in NSCLC. So the normal role, these genes have a normal role in embryogenesis and wound healing. And MET exon 14's skipping mutations cause in frame deletion of juxtamembrane domains, resulting in increased stability and constitutive kinase activation. Now, it is seen in 30 to 4% of non-squamous NSCLCs, but seen in 20 to 30% of the sarcomatoid cancers. So this is one mutation which can be detected with the DNA NGS, but then the RNA NGS is the preferred method, which has much more increased sensitivity. INC and FISH are not recommended. PCR DNA is design dependent. RNA has some technical considerations. As far as NGS is concerned, the DNA NGS is design dependent, potentially detects many mutations, but then RNA NGS is more sensitive. So RET receptor tyrosine kinase and RET fusions in NSCLC. So this RET gene has a normal role in neural and genitourinary development, and this mutation is found in 1 to 2% of NSCLCs and 10 to 20% of papillary carcinoma thyroid. So majority of RET mutations fusions can be detected by DNA NGS, but again, like the MET exon 14 skipping mutations, the RNA NGS is the preferred method with increased sensitivity. So methods for RET fusion detection, IHC we have already seen that potential local implications, significant false negatives. FISH also leads to a lot of false negatives. So both should not be considered. DNA and RNA NGS can be considered. They both have very good sensitivity, with RNA NGS being preferred. Testing for NTRK fusions. Options are IHC, RNA or DNA NGS, FISH, RT-PCR. Advantages and disadvantages of all. RNA NGS is most sensitive. IHC is widely available, and has a very fast stat, so can be used as a screening tool. But then, if it is detected, then it has to be confirmed by an NGS. Reflexing to NGS via versus IHC reasonable for NSCLC due to low prevalence of NTRK fusions. So we see that advantages and disadvantages of all these methods. IHC gives you rapid results. FISH also gives you rapid results, but then this has to be confirmed by the NGS. It will lead to less depletion of tissue. Fusion partner and position are also defined, and definitely the sensitivity is increased. So choice of assay will depend upon the choice of first assay will depend upon the institution, resources, clinical context. reflexing to NGS versus IHC reasonable for NSCLC due to low prevalence of NTRK fusions. Now, HER2 mutations in NSCLC, there can be mutations as well as there can be amplification. They are present in 3 to 5% of NSCLCs, mostly exon 20 in frame insertions, mutually exclusive with other mutations, as we have seen with the KRAS thing, mostly seen in never smokers, worse OS than some other subtypes. In NSCLC, HER2 mutation amplification must be identified using an NGS panel. IHC used to assess HER2 overexpression seen is 59% of NSCLC, that is 2 to 3, 2 plus or 3 plus, can be seen up to 30% of the patients. So this is the 2022 treatment paradigm for molecular biomarker positive NSCLCs. I think we have already discussed this in the initial slides with the MET14 exon 14 skipping mutations. I think we forgot to discuss there. The capmatinib or ipotinib are available. Now we come to PDL1 overexpression in SCLC. We can see that there can be a companion diagnostic type or there can be a complementary diagnostic type. The DACO has 22C3 and 28.8, and the Ventana platform has SP263 and SP142. So these are the antibodies and various methods which have a different scoring system, different platforms, and are done along with the different antibodies like pembrolizumab, durvalumab, atezolizumab, nivolumab. For nivolumab, it is 22.8 DACO. For Ventana, for atezolizumab, it is Ventana SP142. For durvalumab, it is Ventana SP263. And for pembrolizumab, it is DACO 22C3. So scoring system for pembrolizumab, we can see that PDL1 positivity is known as a TPS of more than equal to 1%. PDL1 high is a TPS of more than or equal to 50%. And for durvalumab, PDL1 high is considered to be a TPS of 25%. And for atezolizumab, PDL1 positivity is known as TPS of more than or equal to 1 or IC of more than or equal to 1. And PDL1 high is considered to be as TC of more than 50% and IC of more than 10%. And for nivolumab, PDL1 positivity is TC of more than or equal to 1%. So these are the different scoring systems depending upon the antibody used to detect PDL1. So biomarkers for immunotherapy in SCLC is a controversial topic. PDL1's sole current biomarker able to guide immunotherapy right now. But this biomarker is imperfect because we have seen that PDL1 negative tumors can still respond, especially when we use them with chemotherapy. So whether this is due to some synergistic effect, we don't know. The tumor mutation burden, former marker for response, not currently used because in the checkmate studies, there were conflicting correlations with it. MSI high, not used or relevant in lung cancer. LAG3, possibly related to resistant immunotherapy, is currently being studied. So conclusion, biomarker testing in SCLC has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Sample should contain adequate tumor content that is at least 10%. Ideal TAT is 2 weeks, 10 working days. High throughout platforms such as NGS can be used to screen several genes at a time to provide results within the estimated TAT. So this is the summary of various oncogenic targets and the testing methodologies that we have already discussed. Clinical guidelines strongly recommend broad molecular profiling to identify rare driver mutations for which effective drugs may be available, or to appropriately counsel patients about the available clinical trials that can come up in the future. So as the survival has increased, so we don't know after with every passing year there are new drugs coming up and there are new treatment options available. So broad molecular profiling is a key component of the improvement of care in patients with NSCLC. Thank you.
Thank you, Dr. Abhishek, for that elaborative presentation. We have our next speaker with us, Dr. Rajat Bajaj. He is the senior consultant and director at Fortis Hospital, Noida. He will be speaking on the overview of lung cancer. Dr. Rajat?
Hello. Yeah, am I audible?
Yes, Dr. Rajat, you're audible.
Okay, good evening, everyone. I thank the organizers, Dr. Manish Sharma and his team for having me here. And I was listening to an elaborate talk by Dr. Abhishek Yadav. It was always a pleasure to listen to his talk. Is he there?
Yes, he is here. He is there.
Hi, Rajat. I'm
Dr.
here.
Abhishek? Dr. Abhishek, it was a very nice talk. I want to ask you, are you doing NGS in most of your patients?
Yeah, now I've started using it in most of my patients.
Okay, and do you think that the rates of pickup of mutations has improved after the adopting of NGS by most clinicians?
Definitely by a small percentage at least they have increased. There was a patient which was in EGFR negative in by the PCR, but when we did an NGS, it was an insertion 20 mutation positive. That patient is presently on amivantamab. And there's another patient of mine, which was when we did the single gene testing, they were all negative. But when we did NGS, came out to be the ret positivity. Though the drug against that ret alteration is not available in India, patient is on chemotherapy only. But we have seen that it definitely increases the number of actionable mutations that can be detected.
Dr. Rajat, are you doing biopsy and NGS at every progression?
I think we have missed Dr. Rajat.
Yeah. Okay, nice, very nice.
Dr. Rajat, you are doing repeat biopsy or NGS at every progression in lung cancer?
Not at every progression for sure. But then
Ideally, it
it's
should
a
be done.
it's a broad sort of a question. Actually, it depends on what we are giving in the first line. If the patient is on IO, then there is no point doing the NGS post IO. But if the patient is on a TKI for the resistance mechanism, certainly the NGS should be done. And possibly at progression, a liquid NGS will be better than the solid NGS.
Okay.
So we are doing small tests. The limited NGS is what we are doing mostly, and we are leaving Guardant and Foundation one for Dr. Abhishek Yadav to
So
do.
you are not doing comprehensive panels.
That Yashoda is doing.
Okay.
We are doing less.
So
So
No, we are just doing in mostly patients we are doing only 50 to 20 genes that are most commonly being found.
okay.
Guarded we cannot do in every patient. Guarded we cannot do in every patient. My patients are not that rich.
Yeah. Right. They're taking amivantamab. They're poor people.
No. Rich people cannot take amivantamab. Only panel patients can take amivantamab. This is vice versa.
Okay. Right. So I think we start with the overview of lung cancer now. So then can I have the next slide, please? So we're talking about lung cancer. We know that it's a very common disease. This is Globocon 2020. But if we do 2020 tells us that lung cancer is the third or the fourth in terms of incidence. But Globocon 2022, I recently came across, which was incidence and mortality, both lung cancer right at the top. So this tells you as to how things have changed at a very rapid pace as far as the lung cancer is concerned. Next slide. So with this rapidly evolving scenario which is there for lung cancer, next slide, what we have to certainly keep in mind that the AJCC classification also has changed, and there has been an upstaging of lung cancers. Now stage 1B, which was previously became stage 2A. Similarly, there was a change in the stage 2B being converted to stage 3A, which was a T size or a tumor size more than 5 centimeters. So that way, what actually it has been attempted is to uh, probably over treat rather than under treat, so that we can have a better aim at cure. Because if we can once cure the patient, it will be great. If we not able to cure and the patient converts to a palliative intent, then we are only chasing the disease. Next slide. So there are various tools to investigate this type of a disease, starting from bronchoscopy to a CT chest or a PET scan to an EBUS, mediastinoscopy and MRI. So MRI brain, a lot of discussion happens on MRI brain. So apart from stage 1A should be done in every patient. Even in a stage 4 disease, it should be done. And even if the patient is not having symptoms, it does tell us the baseline status. Next slide. CT chest and PET scan, there can be a debate on which one should be done, but then all the guidelines, including NCCN, do recommend the PET scan, FDG PET scan, to be a more sensitive tool to pick up distant metastasis. If the patient is having a resectable disease, a contrast enhanced CT scan will definitely help us to delineate the various surrounding structures and what should be the approach, whether it's going to be lobectomy or a pneumonectomy. If the patient is having avid lymph nodes, there are in on the PET scan, there are about 80%. PET scan has got both a negative or a value, and that holds true for all the diseases. And addition of PET to a CT certainly adds to the sensitivity and to a specificity as well. Next slide. Having said that, it does not really always matter in mediastinal lymph nodes, and we will talk about that in the next slide. We all know about something called an occult N2, and an occult N2 patient would certainly warrant a mediastinal staging. So mediastinal staging can be done by either an EBUS or a mediastinoscopy, EBUS being a less invasive procedure compared to a mediastinoscopy. Next slide. Mediastinal staging, the recommended techniques are either an EBUS or an EUS. EBUS is more preferred. If there is a clinical suspicion of an N2 involvement, even after an EBUS and EUS, that is when the surgical staging with mediastinoscopy comes into play. In the current era, in the era where there has been a lot of advancement of the techniques of EBUS, with radial EBUS coming in, the need for a surgical mediastinoscopy has actually got depleted or shrunken, but then it still holds its ground if the EBUS and EUS is negative and there is a high clinical suspicion. Next slide. So an invasive mediastinal staging is not always indicated, but then it is indicated if the tumor is more than 3 centimeters in central. If the patient is having a discrete N2, bulky N2, we may forego or preclude that. And if the patient is having a normal mediastinum on CT, but the PET shows that there is an avidity, then certainly it needs to be done. Next slide. Next slide, please. So this is a busy slide telling us about algorithms of mediastinal staging. So what it essentially wants to indicate is that if the patient is having negative lymph nodes in the mediastinum on PET scan, which is called a CN0, and there is a low probability also of the disease being, forego a mediastinal staging. But if the patient is having a CN1 or a CN0 with a high probability, then an EBUS staging needs to be done. Mediastinal lymph nodes being positive can either be non-bulky or bulky. If it's bulky, then tissue confirmation may not be required. If it is non-bulky, then a tissue confirmation is required. Next slide. Lymph node accessibility is not possible with every station, with every modality. We all know that station 5 and 6 are not accessible by conventional EBUS, TBNA, and cervical extended mediastinoscopy. And they are also accessible by left VATS. Apart from that, the regular lymph nodes are mostly accessible by EBUS, and it solves our purpose, probably in most cases, thus precluding mediastinoscopy. Next slide. So, of course, there is a no-brainer that if we go in for invasive procedures and continue to increase the invasiveness of the procedures, the sensitivity rate or the pickup rate for most of the lymph nodes and the lesions is going to increase with mediastinoscopy and VATS, making it as high as more than 90%, and which is lower in case of EBUS because of its lesser invasive nature. Next slide. Please. So this is a slide to tell us the evolution of therapy in lung cancer from a histology based classification to extensive histology based, and then to a molecular pathology, and now with tumor mutation burden. There have been advances and the survival has certainly increased. Next slide. And in this meeting also we have discussed in length about how treatment modalities have changed in lung cancer. Next slide. And this is a picture to tell you that the targeted and the immunotherapies which have come into lung cancer have made it a disease where the survival has increased at least 2 or 3 times compared to the conventional survival. We have a lot of molecular targets now with NGS. We were discussing that in the previous talk as well. Host of molecules are there which can be used according to the genetic mutations which come out, especially in non-squamous histology. Next slide. This, of course, being said in stage 4, but there are cases where we would be able to detect the disease in a limited stage. Next slide. And that would mean that patients can be treated with upfront surgery in stage 1. In next slide. In stage 2 and 3, there there may not always be a good idea to upfront operate, and with the coming in of neoadjuvant immunotherapy, that option should certainly be explored, especially in stage 2 and 3A. If there is an upfront resection, patients who are T size of more than 4 centimeters with adverse features like LVI or a poorly differentiated histology should undergo adjuvant chemo. Less than 4 centimeters, the quantum of benefit is not that much, is what has been told in adequate studies. In patients who are having R1 resection, these patients should undergo radiation as well. Mostly is what is recommended. Sequential can also be done. Next slide. Yeah, we've done this. Next slide. Next slide. Yeah, so there can be a recurrence in most of the patients. Next slide. And that is why this we've discussed. Lace meta-analysis telling us about the overall survival benefit for adjuvant chemo. Next slide. Next slide. So neoadjuvant and adjuvant is preferred. Neoadjuvant, if you are doing nowadays, the current approach is IO plus chemo both. Next slide. Especially for stage 2 and 3A. Dora no has told us that adjuvant osimertinib adds a lot of improvement in disease-free survival, with hazard ratio being as impressive as 0.26. Next slide. Most of our patients who are stage 2 and 3A. Next slide. That there is a possibility to improve both having definitive Imfinzi or Durva. We also know an adequate role of immunotherapy depend on the PDL1 status. We can go to the next slide. If the PDL1 status is more than equal to 50%, then we can give only IO. In less than 50%, we have to give IO plus chemotherapy. Next slide. Next slide, please. Yeah, next slide. We can skip these slides. Next slide, please. Yeah, we've discussed this part. With Pacific, I have already discussed. Next slide. Next slide. Next slide. We've discussed this also. Yeah, so there are a lot of emerging modalities for newer targets, be it CMET or RET, for example. And immunotherapy has improved survival. I've discussed that. Next slide. And there is a possibility of doing IO plus chemo also in PDL1 less than 50%. Next slide. ADCs have come up in NSCLC. In the next 1 or 2 years, we'll see many ADCs like sacituzumab govitecan or datopotamab coming into play. We already have trastuzumab deruxtecan in HER2 mutated patients in the second line. And now the advent of CAR T cell, possibly in solid tumors also, CAR T cell is going to play an important role, and the clinical trials are underway. So with this, I thank you all for your patient back to Dr. Manish and the organizers.
Thank you, Dr. Rajat, for taking us through the overview of lung cancer. So I have a question. I think Dr. Rajat has left. Okay, so thank you so much for joining us, and good night to all. We can, I think, close the session.
Thank you.